exposure is there, maybe because of supra-eruption of lower anterior. Of course, the upper lip is very much thinned. The upper lip length is more, maybe because of aging. So there is no tooth here. So lower means their exposure is more, maybe because of supra-eruption or because of aging. The lower lip droops. Some thinning here, and this length is little more. So actually we should take a scale and we should measure with it. 23 to 24 is the normal range, I guess. Am I right? Okay. So if it is around 26 for this patient, so we have to inform that during smile we cannot give much teeth exposure. Otherwise the patient may demand so you cannot give teeth so longer. So before jumping into, we have to look for the clinical set of photos. So laterally you can see this lip has gone back. Okay. The lower is normal, but here there is some flattening is there. So once we give tooth, that may come out. Even the lip, this thickness will improve. So this is a clinical picture. Upper, I think she was wearing removable denture for a long time. Right, so some which lower also dentures few teeth only remaining. Maybe because of the denture wear, there is some reddish, maybe fungal irritation something. So long-term denture wear, we should not get fooled by this ridge thickness. It may be only soft tissue. Okay, inside bone may be very thin. So when we see clinically, we may think we got very good buckling of it, but the bone may be very less. So long-term denture wearer, there are little high-risk cases because of resorption also will happen. Not only in the height level, buccal level, and not only that, the bone also will become soft and smooth. The bone will become cancerous. So once we see the X-ray, we will understand what kind of problems we are going to face. Okay. So this patient is not course patient. Straightly he came from, I think, UK, I guess. She is very anxious, very tense. So what we do is, during surgery, don't ask any doubt. Three people we will assist. Other 3 will sit here and see through screen. Okay. So first we will plan for the lower jaw. So whenever possible, see this view before starting the surgery. You will get an idea about how much alveoloplasty we have to do. Definitely this part is gone up. And not only that, because of this natural tooth, the patient will be hitting, no? Only forces will go there. You can see the knife edged resorption there. Though in clinically the ridge was good, but in X-ray you can see it is thin because of resorption. The mental foramen. As aging happens, the mental foramen for some patient it becomes smaller. You see it is very small here. Okay. Now we will see the panoramic view. So this we have to flatten it. Okay. Otherwise we will have difficulty during the process construction. We cannot give a proper tooth here. Okay. This happened for us in the initial stage, initial period. Then we understood alveoloplasty is the important link. That is why many doctors, they are not doing alveoloplasty, especially when it comes to full mouth. Alveoloplasty plays a very important role. So to give prosthetic space, to create a uniform bridge gives uniform forces to the implant and underlying implant. If the bridge is thick very much, here the bridge is very thin, it gives uneven forces to right and left side, leads to problem. And you are removing the thin, poor quality alveolar bone. So even after 6 months, if the patient is coming, you won't see any gum shrinkage on the gap. Usually after 3 months, 6 months, the patient comes with a lot or lots of gap. But 95% you won't see if you do a proper alveoloplasty. Even after 1 year, it will look like good. Okay. So it is a high resorbed case. Distal mandible, heavy resorption. Maybe because of denture wear or long time after extraction. Okay. So how to plan for the lower jaw? First two cases it is the upper jaw, right? So how to plan for the lower jaw? Usually it is 6 implants or 8 implants, sometimes in between 7 implants. Mostly between these 3. Okay. When to go for 6, when to go for 8. Okay. Very simple solution. When there is severe resorption like this, definitely you cannot place a very good implant. Only short implants we can place. Go for 8 by 2 take it is. Okay. So any resorption cases. In the second scenario, when the bone is very much osteoporotic, the bone is very much cancellous, you cannot get a good stability. Each and every implant will be a 20 or 30 mm stability one. Even in the last case, lower jaw, the right side one implant was not very stable. Stable but 30 newtons something. Some areas it was good, some area it is not. Wherever you are reaching the cortical bone, you are getting good stability. That premolar we are not going and catching any lingual cortical, just it is in the intermolar area. Anterior we got good stability because of the crestal cortical bone, it is tightly holding the crestal part, right? So whenever you feel like the bone quality is poor, the stability will be very less, why to take a risk? Put in 8 implants, be very good. 6 implant is ideal cases. Here also good bone is there, here also good bone is there. 6 implant is enough. In the beginning stage, nothing wrong in placing more number of 8 implants is safer also. The 2 implants will save us. So how to place this 6 or 8 implants? So you are dividing the jaw into 2 segments. Mental foramen, mental foramen. This is called the interforamina area. This is distal mandible. Okay. Here the key area is interforamina area. Imagine in R14, 1, 1, 1 and these 4 implants, they support the entire bridge. Here we are going to give one more implant here. And apart from that, we may give 2 more and 8. Definitely it will be a success. So the key part is the interforamina area. Okay. So as we know, the foramina is in the 5 region, right? 5. Okay. So our aim is to place a good 4 implants in the interforamina area. 4 implants decently. You can place more than 4 also, but the risk is more. The implant may very close to each other. 4 is more than enough. Don't try to place more than 4. Okay. So where to do that 4? Okay. One is in the lateral incisor, very simple, lateral incisor. And of course in the 4 regions, right? 4 regions. So what is the risk involved when you are doing implant in the lateral incisor area? Lingual perforation we should avoid. How will you avoid it? By slowly doing it, feeling the resistance and respecting the resistance and stopping the resistance. Okay. When the police is there in the signal, we are stopping, we are respecting the trajectory. The same way, the resistance we should respect. What is the risk in placing this 4 implants? If unknowingly, if you tilt like this, here we may draw safely, but during drilling it will go distally. Okay, we may. How to avoid this problem is expose and see the mental foramen. Just open it and you will see the shiny white thing bundle. You don't have to expose the entire foramen. Just open it, and the moment you see, you can take a probe and put it in the foramen also, just small depression. And just drill anterior to it.